This week in Pediatric Oncology, the podcast exploring hot topics and exciting advances in childhood cancer. TWiPO is produced by Solving Kids Cancer, nonprofits located in New York and London dedicated to improving research and supporting families, because every kid deserves to grow up. Subscribe to TWiPO through your favorite podcast platform.
This week in Pediatric Oncology, the podcast about new advances for childhood cancer. Hi, everybody. Welcome to episode number 87, recorded on April 30th, 2021. I'm your co-host, Tim Cripe from Nationwide Children's Hospital in Columbus, Ohio, affiliated with The Ohio State University. And I'm here with my co-host, Brenda Weigel from the University of Minnesota. Welcome, Brenda.
Thank you, Tim.
Today, we have another special guest with us, Dr. Greg Friedman from the University of Alabama in Birmingham. Welcome, Greg.
Thank you, Tim. Very happy to be here.
So Greg is a star in the field of phase 1 brain tumor research and has just had a seminal paper published in the New England Journal of Medicine that we're going to talk about today. And we chose this topic in part because tomorrow launches National Brain Tumor Awareness Month. And so it's a timely topic. Dr. Friedman went to the College of William & Mary, where he got his undergraduate degree, and then the Medical College of Georgia for his MD degree. And following that, he did a pediatric residency at the University of Alabama, Birmingham, and his fellowship there in pediatric hem-onc, where he then stayed on as faculty and is now the director of the developmental therapeutics program and the site PI for the network that Brenda runs, the PEP-CTN. And so he's quite accomplished and experienced in early phase novel therapies for children with brain tumors. So Greg, tell us just first maybe some of the background, what led to this study, this paper that you published, what sort of gave you the impetus to do it? Why did you get excited about testing the use of live viruses in children's brains?
Sure. Well, when I first was back starting up in fellowship, one of my mentors I had heard give a talk on oncolytic herpes simplex viral therapy. This is something that had been developed at UAB and years earlier and was being tested in adults. And I heard him give a talk about that, found that quite fascinating. And then as I was starting fellowship in that first year, when you get to see the patients and the significant toxicities that they're experiencing and especially with brain tumor patients, the poor outcomes that many of the diseases that we see the patients have with those diseases, that led me to seek out this individual as my mentor, Yancey Gillespie, to discuss had they ever considered looking at that therapy for pediatrics. And they really had not thought about that a whole lot. Their focus was adult high-grade gliomas. So that gave me an opportunity to join the lab and look at the way how well this therapy worked in pediatric models, and then work towards the first clinical trial of this therapy in children.
So can you tell us just a little bit about the idea behind it? Because you're injecting a live virus into a brain, and the virus is known to cause encephalitis, normally herpes virus,
right?
As well as cold sores for those of you who don't know about the encephalitis part. So that seems like a scary prospect, but why did you think it would be safe, and why did you think it might do something positive?
So the virus, all the genes have been identified for the herpes virus, including the neurovirulence gene, which is responsible for the virus's ability to infect and kill normal cells. And so when that gene is removed, then the attenuated virus or the modified cold sore virus can't, in fact, it can get into the cells, but it can't replicate. Normal cell is able to shut itself down once that gene's been removed. Tumor cells, simplistically, they don't have a good way of shutting themselves down. And so the virus is able to replicate in the tumor cells. So it provides sort of a targeted, guided attack towards the tumor cells while sparing the normal cells. And then another really important part of that is the fact that the virus is very immunogenic, meaning it stimulates a robust immune response. And what happens is those immune cells come in to the tumor and first are coming in to remove the virus, but at the same time can start to recognize the tumor. So it's sort of a cross-pollination where it starts to recognize those tumor proteins that have now exposed because the virus has lysed and destroyed the cancer cell. And so you can get the patient's own immune system to start attacking the tumor. And we think that part's actually even more important. So it's sort of this dual attack, but what makes it selective is the fact that the neurovirulence gene has been removed so that it can't damage the normal cells.
And I noticed in the paper that when you looked for the herpes virus, when you looked for that cold sore virus, that you couldn't find it. You couldn't find it in the body fluids, or you couldn't find it, the actual virus, in the samples that you had from the brain tumors. Do you think that's a good thing? Does that mean that it's not causing infection, or is that a bad thing?
We think it's a good thing for a couple of reasons. I think the virus, the immune system comes in and removes the virus. We don't think the virus hangs around for all that long. In preclinical studies, the virus could be detected for about a week or so. So the immune system will remove the virus, and every cell is not killed by the virus. We know that aspect as well. So really, that's why that secondary anti-tumor immune response is sort of what we believe to be the critical component. So when we looked at patient tumor tissue anywhere from 2 to 9 months after infection, we saw a bunch of immune cells there, and we had treatment tissue from or prior to the treatment, we had tissue that we could compare to, and we saw this increase in all these immune cells there, but no evidence of virus. That leads us to believe that it's most likely that these immune cells are there to attack the tumor and not there just because the virus had previously been there.
So that's a good thing, right? That's a good thing, because you're getting that immune response that didn't happen on its own. The virus is actually generating that immune response, which is incredibly exciting. Do you think that there are differences between sort of the virus product, the G207, the name of the oncolytic virus, that are different or better than other ones that have been tried in the past? Like, what makes this one, certainly in your study, seem like it might be hitting the mark, so to speak, whereas other ones that have been tried haven't maybe done as impressive a job?
Some of that, I think, has to do with, there's been different viruses that have been tried or are being tried, different than just herpes virus. As far as other herpes viruses that have been used, there's been, I think there's differences in the strain of the virus, but they likely can create similar types of responses. They're both, it really has to do with, I think, study designs and things like that may be related to why there's differences sometimes. But certainly between the different types of viruses, so for example, herpes virus versus reovirus versus a measles virus or other types, there could be differences based on those viruses.
And I guess I would add to that the viruses haven't been thoroughly studied, so no one's really compared different ones head to head or anything like that.
Exactly. Yeah, that's a great point.
Yeah. Tell me what the experience was like for the patients. I think you put in up to 4 different catheters and had to infuse it over time. And what was it like for a patient to enter the trial? So if someone's listening and they may want to enter a future trial, what might it be like for them? And then maybe go on to tell us what the results were in terms of, how much it worked.
Sure. So I think it sounds more involved than it is ultimately. The way it works is that first we screen the patients after they've consented to go on the study and make sure that there are safe path for the catheters to be passed to the tumor. And that's determined by the neurosurgeon, Dr. Jim Johnson, who's involved with that. And also this study was opened and they treated a patient also at Nationwide Children's Hospital, as you know, Tim. And so once that's determined that there's safe path, then the following day they're under anesthesia. There's first a biopsy to confirm that it's actually recurrent tumor there. Obviously, we wouldn't want to infuse it if we didn't find evidence of tumor. So once tumor is confirmed, then the neurosurgeon passes the catheters, and this is all sort of predetermined based on the MRI to try to cover as much of the tumor as possible. And these are, this is not near as extensive as when the neurosurgeon went in usually at diagnosis and does a very large resection. So this can be done with just stereotactic guided type approach. So it's not as involved. They're very small little incisions, for example. And then patients recover in the ICU like they would after any type of neurosurgical procedure. The next morning, we would check the catheter placements with a CT scan just to make sure that they're where we think they are. At that point, the virus is infused over 6 hours. That's a slow infusion just with the goal of having it spread as far as possible throughout the tumor. Then an hour after the infusion, the neurosurgery team pulls the catheters at the bedside. So we just use a little bit of topical cream to numb up the area. And then the children are transferred to a floor bed and are monitored in the hospital for a couple of days. We had 4 groups of 2 doses of virus and then 2 doses of virus with a single dose of radiation. So those patients the next day after the virus infusion would receive the single dose of radiation. And that was being used based on preclinical studies, which indicated that increased virus replication and spread throughout the tumor. So patients were monitored in the hospital for 2 to 3 days and then would have an MRI. And then after that, were followed as outpatients. We would see them a week later and 2 weeks in a month, and then every couple of months after that. And we partnered with the hospitals because patients came from all across North America, and we would partner with the hospital so that in between visits to see us, they would be seen by their neuro-oncologists locally.
The patients who had the radiation in that cohort, had they had prior radiation, and did that matter?
They did have prior radiation. This is a single 5-gray dose, which is a fairly low dose. It's a little bit more than we might give if we're giving 30 individual fractions, but it's still a low dose. And we didn't see any increased toxicity at all from giving the radiation. And when we looked at the tissue, it's hard because we didn't have post-treatment tissue on all the patients. But it appears that there's increased immune cells in after receiving the radiation. But because we don't see any increased toxicity at all from it, the plan would be for the next study to include that single dose of radiation.
Greg, can you describe, what findings you feel are the most important coming out of this study? What are the key things that you learned in this study?
I think 3 key findings. First is that the virus was safe at very high dose levels. So we were infusing up to 100 million virus particles directly into the tumor. The side effects were mild and infrequent, related to, or that we could attribute to the virus, and there were no serious adverse events related to the virus. So it was actually quite safe and less types of side effects that we might see with more standard types of therapies. So that was very important. It didn't seem to adversely affect quality of life after treatment. And in some ways, where you have to give drug every day or drug weekly, getting that one-time dose, that was actually an enhancement of quality of life. So that was the first thing. Second, although it wasn't the primary objective, we assessed the efficacy of the therapy and found radiographic or pathologic, neuropathologic, or clinical responses to the therapy in 11 of the 12 children. And the survival that we saw appeared to be seemingly longer than we might expect for progressive high-grade glioma. So we know for children that have a recurrence with high-grade glioma, survival unfortunately is less than 6 months on the median survival. For these patients on the study, it was 12.2 months. Obviously, we'll need to check that in a phase 2 study because this is only in 12 patients, but that we didn't see signs or evidence that we had a more favorable group of patients or anything like that. So we feel like it's very promising, and we'll confirm that in the next phase of the study. Then the last part that we think was extremely important was that there was this striking infiltration of the immune cells when we compared matched pre-treatment and post-treatment tissue. And classically, pediatric high-grade gliomas are what we call immunologically cold, meaning they have very few to no immune cells there. And this is why they're not responsive to immunotherapies, drugs like checkpoint inhibitors, because if there's no immune cells there, then there's nothing to attack the tumor. But we saw this change from cold to very hot with an abundance of these tumor infiltrating lymphocytes. And I think that's, could be the most important finding, really, is because it's really the first critical step needed to have an effective immunotherapy, is that there's immune cells there.
Building on that point, do you plan to do combinations then with checkpoint inhibitors and other immune therapies in the future?
Definitely, that is part of the plan. The phase 2 trial that's being developed and hopefully will be open later this year is to use a similar type of design with the virus and 5-gray dose of radiation, but for patients that subsequently go on to have an initial progression, and that's could be a whole nother discussion, is in how do you define that in this type of therapy, which can be quite difficult. But checkpoint inhibitors will be part of that, part of the therapy at that point. We'd also like to move this therapy up front in newly diagnosed patients. And really, we've seen that we haven't found a tumor type, a brain tumor type, that's not sensitive to killing by the virus. So we really are going to try to expand this into all different tumor types.
And Greg, with that plan in mind, and I think that sounds fantastic. What do you see as some of the biggest challenges with bringing this type of therapy forward, be it both at the drug development level or just implementation level, and any thoughts of how to overcome some of that?
Some of it is going to be the teaching that's involved to get, so for example, neurosurgeons it's not standard that they're placing catheters into tumors. So when we opened the study at Nationwide Children's Hospital, our team traveled to Nationwide Children's Hospital to spend a day there to teach the process, because of that a little bit more complicated part. So when we open this to the phase 2, we're going to sort of open it in stages as we teach each of the institutions about the surgical part of this and about the infusion. So that's one aspect is, as we move it forward, getting more and more hospitals comfortable with this type of treatment. I think, other things, a challenge, as I kind of alluded to, is just the learning how to measure response with this type of therapy. When you're infusing a virus into the tumor, you can't use the normal type of response measures that we're also used to, where you just measure, did it get smaller, because it may actually get bigger because of immune cells going to the area. Sometimes because it's intratumoral, that you get changes inside the tumor, but maybe not changes outside. And so we find it difficult to use the standard measurements that we use. And on MRI, it can be difficult as well. And so, these are things that we need to work through. And it's something that we're also been working through with the FDA in terms of how do you move, if this was a drug that in the phase 2 is successful, how do we move to an approval with using the standard types of criteria that the FDA likes to use? So that's something we've been working with them, and things, using new ways of looking at things like overall survival, and using pathology to show changes, as opposed to strictly defining something as a partial response or a complete response. I think the best example of that is from the paper where we show a patient with the cystic changes in the tumor. And if we try to use standard criteria and that patient is over 4 years out without a single other therapy, if we tried to use the standard measurement criteria, the tumor is 20% bigger than it was. But however, if we subtract out all the cystic changes, it's 40% smaller, and the child hasn't had any other therapy. So we know there's a response, but we don't know how to define it the way we are used to defining it.
A quick glance to the past. When did you first start in earnest, really trying to say, I want to set up a trial like this because I want to give the audience a sense of how long it took you? And then what do you see in the crystal ball over the next 5 years from now? Are we going to be able to do things faster than what it took you the first time? And what are we going to do? Where are we going to be in the field then?
Sure. So, I think when I first started in the lab, that was the goal, was to move to a clinical trial. But some of that initially was obtaining preclinical data to show that these tumor models were sensitive. In terms of when we earnestly started, it's a good question. I think
I remember that far back. Huh?
It's hard to say exactly, because we were looking at another virus that's being used at UAB as well to decide which one to advance. But ultimately, I think it probably was somewhere around 2013, 2012, 13 is probably when we were initially getting going with this concept, and then working to get an investigational new drug approval. And so those types of things took a while, and there was a lot to learn along the way. But I think now things will move quicker. We still have to, to move through the consortiums and get approval of LOIs and CTEP and all those things that Brenda knows so well through CTN, whereas I might have thought, oh, we could get this up and running in a few months. I learned, that there's all these steps along the way. However, once we get it open, then I think we'll be able to move fairly quickly, because I think there haven't been too many promising therapies right now for this type of disease, and we're receiving a lot of interest about it across the country and outside the country. people interested in giving this therapy a try. So I think we'll be able to complete a trial, quicker than we were able to do it as a single institution or just 2 institutions. And then we planned, as I mentioned, we planned to kind of on the heels of opening that trial, hopefully moving forward with several different trials. So that's the goal. And the goal would be that this phase 2 trial would lead to approval of the therapy. And that's what we've been working with the FDA on. And that's also part of why we don't have a trial already open right now, is we want to make sure we get all this taken care of before we start the study.
And Greg, that is so exciting because, as you said, there's so few available potentially beneficial treatments for brain tumors in general, and particularly the high-grade gliomas in children. And I think this is tremendous. And we're coming up on the end of our time. It goes so quickly. I'm always amazed, and there's always more to discuss. But I wanted to see if Tim had any last questions, and then I'll look, Greg, to you for any last comments.
My last comment is really just to congratulate you on this work. And I think it's a big boost for the field. There's still obviously a lot of work left to be done, and whatever we can do to help you, we will do. So good job.
Thank you so much. Appreciate that.
Yeah, and I want to extend my congratulations as well. This is a very Herculean lift to bring a therapy like this forward. And I also really, even though it was not the primary aim of the phase 1 study, to have almost all of the patients that you treated demonstrate some type of clinical benefit, pathological benefit, radiographic benefit is outstanding. But I think more to the point, demonstrating the immune activation, the biologic endpoint is crucial. So I look forward to the next steps. I look forward to seeing the trial. I think with the enthusiasm, it will accrue quickly because as you said, there's not a lot of options, and this is certainly appears to be promising, but lots more to come to actually cross that hurdle. So Greg, thank you for joining us. Thank you, Tim, for co-hosting. And thanks to the team at Solving Kids Cancer, a nonprofit charity dedicated to improving survival through creating novel treatment options for children. Remember, the more we learn, communicate, share ideas, and work together, the faster we'll reach the day when all childhood cancer is preventable or curable. As always, keep up the fight, and thanks for listening to This Week in Pediatric Oncology.
We welcome your comments, questions, or thoughts on topics for future episodes. Just drop us a note at TWiPO@solvingkidscancer.org. You can follow Dr. Cripe on Twitter at KidsOncDoc, send an email to Dr. Weigel at weige007@umn.edu, and find all TWiPO episodes at solvingkidscancer.org.